I was asked to take on the concept of platform switching. This is obviously an area that I've been involved with in various ways over the years and always very concerned about. The bottom line is everything we do, it winds up somewhere along the line, somewhere in the sulcus. The health of the tissue, the survival of the tissue, the look of the tissue, and so on. So I shortened this part because, as you obviously all know what platform switching is, although yesterday the beautiful presentations were magnificent, they were absolutely gorgeous. And we certainly established the fact that bone stays at a much more coronal level on this kind of a platform switching implant, similar to what, of course, ankylosis had for years. The question is, what was left out yesterday? Most of the presenters did not show you word about the soft tissue. They showed you the clinicals, of course, some gorgeous cases. But what about the biology? What about the soft tissue? What about biologic width? I didn't hear yesterday the word epithelium once. I didn't hear the word connective tissue zone once. Now, that's not to criticize the people yesterday. Their focus was bone. But now let's take it to the next step. They've set the stage for me perfectly to be able to talk about the soft tissue, and not just from a clinical standpoint, which we will discuss, but also from the biologic standpoint. We all know, of course, that every tooth has a junctional epithelium, gingival fibers, and periodontal ligament. Now, do all teeth have biologic width? Does every implant have a do all implants have a biologic width? No matter what implant it is, once exposed to the oral cavity, do all implants have a biologic width? How many people say yes? How many people say no? How many people just don't know? How many people don't care? Well, you better care, because that's what it's all about. This is a very high sophisticated group, and most of you know that every implant, once exposed to the oral cavity, has to have a biologic width. If you don't know where it's not whether or not the biologic width exists. Let's get this one right. Anybody tells you there's no such thing as a biologic width, there's the door. The door's right there. Just walk out. Enough is enough. Let's get this one right. Every implant has a biologic width. The only question, and here's where the finesse comes in, and this is what this meeting in part is all about, where on the implant or the implant abutment combination is the biologic width? Every time something comes through bone, like a tooth or an implant, the bone protects itself from the outside environment. Bone never stays exposed to the oral cavity. It will always cover itself with periosteum and connective tissue genetically always covers itself, of course, with epithelium. So there's always a biologic width. The question is, where is it? Where is it? What shape is it? What size is it? And where on the implant or implanted abutment is it? So every tooth has one, of course, because it erupts through the bone. And there's a zone of sulcus, the epithelium, and the connective tissue fiber. And on teeth, it's about 2 millimeters. As you know, these are averages from the Gargiulo, Wentz, and Orban article in '61. Do all implants have it? Yes. They all have a junctional epithelium. They have to. And they all have a zone of connective tissue. That's the same as teeth, the hemidesmosome adherens. But the gingival fibers are present, but there's no cementum. So herein lies the first difference. And we always have to remember this, and we forget this, because we're only looking at x-rays. We don't see histology. So that's fine. That's the first level. And the bone, of course, sets the tone, but tissue, but that's good. But tissue is still the issue, isn't it? As David so beautifully quoted. And then, of course, instead of a ligament, you have osseointegration. And on a regular standard implant, it looked like this, doesn't it? This is after, however, what we've learned is that these pictures that we had were after repeated removal over the abutment. Where is the junctional epithelium? It's below the abutment interface. Because this was taken on and off numerous times. By the way, if you didn't take it off numerous times, there are different things that happen. We'll discuss that in a minute. And this is, of course, what we saw yesterday, what we've seen for the past 35 years or so, with the classic Brånemark type of implant, the non-platform switched implant. The bone goes down where? Now, it is not anything magical about the first thread. This is not due to mechanics. So let's clear that one up. That is not due to mechanics. That will happen exactly like that if you just take the abutment on and off a few times and never loaded the implant. That is not from a thread design. It's not from a pointed thread. It's not from a rounded thread. That is from the distance from the abutment down. How far is that first thread from the platform switch down? About 1.5 to 2 millimeters. That is pure biologic width. You could have a press fit implant, like the old IMZs or Calcitex, and what's the biologic width? The same 1.5 millimeters formed without any threads at all, as long as there was a textured surface up there. Got it? So the thread design, of course, helps stabilization. It helps give you, as Paulo so beautifully pointed out, it helps give you stabilization, but it does not, and it gives you more surface area. but it does not stop this from happening. This will happen no matter what happens on this design implant without a platform switch. If you initially place an implant like this below the crest of bone, what happens? The bone doesn't like the microgap, as we heard yesterday on standard implants. The bone doesn't stay there. And so what happens, as you all know, is that this moves away. Can the epithelium stay on the abutment? Yes. Even without a platform switch, that definitely happens. Well documented. This is a very important picture. This is what happens because the bone doesn't like that interface because of two things. One is microleakage, as we heard so much yesterday. Beautifully defined, and that's true. And this is one of the problems with these old implants. They have microleakage, this design, especially the old transepithelial components that Brånemark had. The other thing is micromotion. A micromotion still may be a factor. That's why we don't see bone on the abutments. That's one of the main reasons, that and the surface texture. But obviously the ankylosing implant goes as close to possible as being functioning almost like one unit. However, micromotion may still be there, even though the screws don't loosen. There's one of the finest connections, if not the best connection out there. No question about that. However, we must realize that the soft tissue can stay on there, and does, unless you break the seal. Even if you have inflammation here, by the way, you know what's interesting? You go back to the original Brånemark histology from almost 25 years ago, that they showed that with leakage, the definite leakage with the old transepithelial components in the dogs, and with Bergling and Lindy, they showed inflammation here, but the epithelium was still on the abutment if they never took it off and brushed the animal's teeth. So although there was an inflammatory infiltrate, the bone moved down, but the soft tissue stayed on the abutment. And there was a zone of inflammation right here. Rather interesting. So that after 6 months in the dog of brushing. So the key is taking it on and off, as well as microleakage. And so the key is, like you heard, one abutment, one time. This is a rather critical point. So this moves down as you take it on and off, and Berglund and Abramson certainly showed this work in '97. And he also showed that you can take it off in 2001. You might be able to take it off once and get this tissue to stay on there. What we're looking for, as you'll see in a moment, is this. Can we keep the abutment, can we keep the soft tissue high? Because it's not just enough to have the crestal saved, which we saw so beautifully yesterday, and that does happen. We need to know where the soft tissue is. And you'll see why, again, clinically, how important that is. Where does it come into play? Not with a single tooth. It comes into play with two places. One is the midfacial, the soft tissue recession potential. And where's the other? Two implants next to each other. Certainly an area that I've done a lot of work on with my team at NYU, with Nick and the other people, like Dr. Cho and Fromm and so on. So that's what we want for soft tissue. So it's not just the height of the bone. We need to get supracrestal biologic width. Without it, you will never put two implants next to each other in the aesthetic zone. Mark my words and make yourself happy. No centrolateral will look good with a high smile line until we get this as a group down. That's what the research is all about. That's where we have to go to get this predictably and to be able to stay there. Bone first, great. Now also soft tissue. That's the whole idea of one abutment, one time. And to keep that there. You keep taking it on and off, you're down to here. And then you don't have the support that you thought you had. So, what is platform switching? We're all quite aware of this whole concept of placing a smaller diameter abutment on a larger diameter implant seating. Now the question is, does it overlap, does it not, does it go in? But the basic concept is that the abutment is smaller than the outside platform of the implant. And of course there are all different designs we so clearly heard yesterday. This is here to stay. Some people call it swapping. It's kind of cute. I like that. My wife isn't, my wife doesn't say, that's not what I meant. But understand that the switching, the swapping, the shifting, so you can be shifty and you can do swapping, you can do whatever you want. But the point is, every term is coined by a different company. So you got shifting, you all understand, it's the same thing. The idea is that you have a lateral shift and a medialization of the abutment connection. And of course, George was going to follow after the break, did this beautiful article. So you could see that if an abutment is put on, you can have supracrestal adherence. This is in the monkey study that he had. This is in the monkey study they had. You can see that he had supracrestal adherence right up there. Now, I also want you to see the variability in people. Of course, the bone, you placed it below the crest. Of course, on an x-ray, the bone's going to look great. But where's the soft tissue? Notice that the soft tissue was on the abutment because he didn't change those. With the crowns up here, this was immediate loading. So this stayed right there in the beautiful contact. You notice you don't see any inflammation in the opening. This is really interesting. This is even after loading of these abutments in the monkey. The point is that you have supracrestal fibers. And if we want to hold the papilla up, we just don't have to have bone. As you'll see, we need supracrestal biologic width. And we saw some beautiful work by Dino Wang yesterday. But you take a look carefully, you notice this abutment was never changed. Now we're talking about the soft tissue, not just the bone. You place the implant far enough underneath the bone, yes, you will have a beautiful X-ray. The question is, where's the soft tissue? Does it help me with the soft tissue? Is there such a thing as too deep? Came up in the discussion yesterday, didn't it? And there is too deep. It is too deep, as was mentioned, because the emergence profile of your abutment may have to be modified. If you're using a stock abutment, here's a straight one, won't get in your way. But if you, and that's why you saw Marco talk about using straight, diameters, because the interproximal bone will get in your way, and the palatal bone might get in your way in the aesthetic zone. Notice that you don't see bone directly on there. This is as good a picture as you'll ever see of bone close to it, without touching it. Now this is without loading and without coming on and off. Notice where the epithelium and connective tissue is. That's the focus of this point of this discussion. And what you're seeing here is a beautiful example of biologic width on the abutment. And that's fine. That's okay. But if we keep taking that on and off, what would happen to the bone? Here's the key. If we keep taking this on and off, the attachment gets broken numerous times, and we change that abutment 3, 4, 5 times like Abramson showed, what happens? Similar to what Herman showed in 2000. Those without platform switch. You take it 4 or 5 times, twist it on and off, 4 or 5 times, everything drops down about 1.5 to 2 millimeters. Now the good news here is that this is partly horizontal. That you're still not going to lose bone way down the side. That's what the idea of having this, the biologic width will be there, but it has to be on the shoulder and maybe part of the way down. It varies. But almost all the pictures you saw yesterday were with the abutment not taken off. That's fine, but also remember that it will change and don't look like that if you take the abutment on and off more than once. When they get to 4 or 5 times, like some typical cases, we might wind up not seeing that so perfect histologically. That's the ones we have to look at histologically and look whether or not that shoulder is filled with bone. It probably will not be, because there has to be room to cover the bone from the outside world. If you keep taking this on and off, the biologic width will be partly here and maybe a small part down the side. We see that with most other systems. If you take a look at this original work that we did on non-platform switch implants, we realized there was a horizontal component to the biologic width. And that is the 1.3 millimeters, 1.4. That was that famous article that we did in 2000. So that was the first time we realized that this could be three-dimensional on the non-platform switched implant. And the distance was just under 1.5. That led to the 3 millimeter rule, hoping that that would keep the bone interproximally, but that wasn't enough, and we all know that now. What was missing? The missing was the soft tissue part. It wasn't just enough to hold the intercrestal bone. We still saw the papilla short, and that was a problem. We just published this with a group from Barcelona on platform switched implants with a different design implant. And you can see that this distance shortened down to half. This is human data. This is an interesting piece that we started to see. Instead of 1.3 on the same implant system with the platform switch, it went down to about 0.6, both in height and width. Now that's important. And the ankylose is even better than this. This is really good stuff for us as clinicians. This is now the baseline for where we have to go. So what you're looking at here is that the vertical distance down didn't go 1.5 millimeters down, because the irritant, if there is such a thing, and there sometimes is, depends on the system, is up here, away from the bone. So it's medialized by about 0.3 to 0.5 millimeters, depends on the system out there. And also the vertical distance down, of course, was decreased. Instead of going down to the first thread, was down to about 0.6. So with no platform, you tend to, if the implants are closer to 3 millimeters, you tend to lose this crest and the vertical height. And that's why we thought the papilla was short in 2000. And you can see that without a platform switch, we keep the bone. But is that going to do the papilla? Is this going to be enough? And if this was even up to the top, and only the biologic width was on the shoulder, we must be careful to think that even with a great implant design, with what we're seeing here at this meeting, with the ankylose implant, with the shoulder, and with a good fit, with no leakage, you still have to remember that it isn't enough. What must we still get? One implant, one abutment, one time. We must get supracrestal biologic width in order to hold the papilla between two implants. That's our goal. Everything else is easy. Single teeth are easy, because the adjacent teeth, as you know, hold the papilla up. So this is here to stay. We're looking at this kind of concept, and it's certainly here to stay. Now, platform switching indications, short implants to improve the crown to implant ratio. I look at this case that I did so many years ago. Yeah, it's still working, but boy, this was really fine-tuned. The patient refused to have any kind of sinus work at all. No osteotomes, nothing. and had this limited amount of bone. And I used a standard implant. Now, yes, this has survived for 10 years. 10 years. But take a look at the bone. Today, I would certainly rather do what? A platform switch implant without question. Because on a short implant of 7 millimeters, 2 millimeters of biologic width reformation with nothing to do with occlusion at all, just pure biologic width reformation, you're losing 2/7 of your length. 2/7 is what? What percentage? What percentage is 2/7? Hey, good. Dr. Neeson is correct. 28.5. So you're losing almost 1/3 of your implant length on a short implant without a platform switch on a 7 millimeter implant. Wow. Rather dramatic. So short implants, posterior mandible, posterior maxilla, that's one indication. Minimize midfacial recession. If you keep that buccal plate, you don't need the 2 millimeters. Now you can go down to maybe 1 and still keep the same crestal height. So midfacial work is another area that still needs more investigation, but we're clearly there. Allow implant to implant dimension less than 3 millimeters, maybe 2, maybe 1.5. That's what we have to look at. Here's a study that that Nick just pointed out that we're doing with the platform switch type implant, and how close can you get and still keep the bone? See, there's this little gap here in this particular one, and you see that this gap distance, I shouldn't say gap, this little bone loss down the side of the shoulder. The question is, what is this horizontal distance? We may be able to now get the implants with ankylose and similar designs to get close to as much as even 1 millimeter, especially if we don't take the abutments off, and still keep the interdental bone. So the 3 millimeter rules is for non-platform switched implants from my original study. This is the picture, though. This is the picture you've seen, but we kind of lift this plank a little yesterday, and this is important because I don't want you to get hurt thinking you can put 2 implants in next to each other in a centrolateral position and get away with this. Two centrals you get away with, no problem. The papilla might be a little short, you get a beautiful V-shaped position, and you're great. But if you put a centrolateral in a high smile line, this will be about 1.5 to 2 millimeters shorter than the adjacent papilla on the healthy side. This is an implant with a tooth on one side, of course, and an implant on the other. Notice the bone levels are the same. And that's what we sometimes see. If the implants are 3 millimeters apart, that bone will stay right where it is. And if you get a platform switch, we got to be careful. I don't want you to get hurt, even though the system is great. We're still not perfect. So instead of 1.5 to 2 millimeters down, it may even be up here. You may not lose it. That's okay. Great. I want to save it. Great idea. I think platform switching is here to stay for sure. But what are you missing? You're missing the supracrestal fibers. The tooth has a biologic width. The healthy biologic width is where? On a tooth. Supracrestal. It's not subcrestal. So you already got a start of a zone of gingival fibers of 1 millimeter, an average zone of gingival fibers a millimeter, and epithelium another millimeter. There's 2. Then you got the normal sulcus 3 millimeters with the hypertrophy of the coal, and you got your 4 or 5 millimeter distance. So this could be easily 4.5 to 5 millimeters next to a tooth. That's why everybody shows you single teeth. And correctly so. Beautiful. You want to see a beautiful case? I'll show you a single tooth, especially if you start with normal anatomy. Gorgeous. I'll show you them in a couple of minutes. Can't wait to show it to you. Gee, Dem, what a great clinician you are. Give me a break. These are simple. As you saw the cases that Nick showed, those are tough. That's what separates us, isn't it? For real. And we're not down there yet. But this is short because, and yes, it's good that we're keeping the bone here, but the crest, even if it's there, is not enough. You need to do what? Get supracrestal fibers. That's where the abutment comes in, and the abutment, without changing it, gives us that possibility. And that's what we see. And it might also allow the tooth dimensions when you have short spaces. How close can you get to another tooth? Instead of the 1.5 millimeters that Esposito talked about as far back as 1993, then with the 2000 article that I published, we realized that that's why he's talked about beyond the 1.5 millimeters, because there was a horizontal component to the biologic width of a non-platform switched implant. Now we can look at this and say, I think we can get closer. I mean, it doesn't mean we try to get close, but we certainly know that we could probably get much closer to an adjacent tooth without causing bone loss on the adjacent tooth, which is what Esposito showed. So I think this is here to stay. I think that both buccally and interproximally, this design and concept like this with good fit is what it's all about. So that covers that topic.